Good afternoon, everyone. My name is Genevieve Fishray, and I am the co-chair of the Healthy Lifestyle Committee of the Lansing Alumnae chapter of Delta Sigma Theta Sorority Incorporated. I, along with my co-chair, Andrew Sorrells, would like to formally welcome you to the Chocolate with a Side of Medicine Health Conversations with the Chocolate MDs event. The Chocolate MDs is a group of 4 dedicated, successful, board-certified Black female physicians practicing medicine in the U.S. Today, we'll be addressing chronic conditions that currently affect our communities. And I'd like to take a moment to introduce the president of the Lansing Alumnae chapter of Delta Sigma Theta Sorority Incorporated to provide some opening remarks.
Good afternoon, everyone. As Jen said, I'm Tanya Pratt, president of the Lansing Alumnae chapter of Delta Sigma Theta Sorority Incorporated, and we are honored and excited to have you with us this afternoon. Delta Sigma Theta Sorority Incorporated is a public service organization founded in 1913 on the campus of Howard University by 22 dynamic college-educated women. We were founded upon 3 basic principles: scholarship, public service, and sisterhood. The major programs of our sorority are based upon the organization's 5-point programmatic thrusts, which are economic development, educational development, international awareness and involvement, physical and mental health, and political awareness and involvement. This afternoon, we invite you to engage along with us with Dr. Erin Thurston, Dr. Christine DeReese, Dr. Noelle Marie Fishray, and Dr. Jackie Jones, our talented and fabulous panel, who is going to have some excellent conversation, dialogue, and hopefully useful information that you will be able to take back with you and use throughout the remainder of your day and hopefully your life. At this time, I would like to turn it back over to Genevieve Fishray, our Healthy Lifestyles co-chair. Thank you.
Thank you. Now I'd like to introduce our mistress of ceremonies for the event, fellow Healthy Lifestyle Committee member, Tracie Webb. She will be guiding us through our discussions this afternoon.
Good afternoon, everyone, and let me echo my both my soror sentiment about our excitement that you're here. I have the honor and pleasure of guiding today's conversation, and I'm actually really excited to do this. If you were here with us last year, you know the wealth of knowledge that we have before us today. So you'll get the same level of information and excitement from last year. If this is new for you, you are in for a treat. Because these ladies are dynamic. They really are. And just like Soror President talked about, you'll be able to walk away with information you can use not only today, but as you continue through your life. Just as a housekeeping statement, there is a Q&A function, should be at the bottom of your screen. Please feel free to put questions in there. Someone will be monitoring the Q&A for us. So if you have questions as we continue to talk, we'll make sure that they get answered, obviously hoping time permits. We have a pretty full agenda, and I have a feeling something you may ask we'll get to, but for sure if we don't, please put it in the Q&A function and we'll do our best to get to it. So now I have the distinct pleasure, let me get my notes together here. I have the pleasure of introducing these ladies to you. And as I was able to read their bios again, because again, I was here last year, I was reminded of how dynamic they are. And I'm going to start in no particular order, but I'm going to start with Dr. Erin Ray Thurston. She's a proud South Floridian who matriculated at Howard University, where she majored in biology and minored in chemistry. She was accepted to Ross University School of Medicine, where she studied abroad for 1 year on the Caribbean island of Dominica. Then she completed the remaining years in New York City. While at Ross University, she served as president of the Black Student Union and as an active member of SNMA. After completing medical school, Dr. Thurston was accepted to the Cook County Family Medicine Residency Program at John H. Stroger Jr. Hospital of Cook County. After completion of that residency, Dr. Thurston is now a family medicine physician based in San Francisco, California, where her primary specialties include comprehensive women's health, chronic disease management, mental health, and LGBTQ care. She is an active member of the California Health Corps and continues to play an active role in the COVID-19 pandemic relief force in the greater California Bay Area. Dr. Thurston is also known as Dr. Sunshine, and she's one of the co-hosts and chief editor for the Chocolate with a Side of Medicine podcast. Please join with me in welcoming Dr. Erin Ray Thurston. Good afternoon to you, to some, and good morning to Dr. Thurston, because she's in California. Next up, I have Dr. Noelle Marie C. Fischray. Originally from Lansing, Michigan, she graduated from the University of Michigan. We won't hold that against her because I'm a Spartan. With a major in brain, behavior, and cognitive science with a minor concentration in women's studies, gender, and health. After completion of her pre-medical studies, Dr. Fischray was accepted to Rush Medical College in Chicago, Illinois, where she completed her medical studies while serving as vice president for the Student National Medical Association. After the completion of her studies, Dr. Fischray was accepted to the Cook County Family Medical residency. During her time in that program, Dr. Fischray received the Family Medicine Leads National Conference Scholarship for her demonstration of leadership within the field of family medicine, in addition to the Residency Research Award for presenting her research topic on incorporation of simulation to enhance the family medicine inpatient curriculum to access critical care management among residents for hospitalized patients at Cook County. Currently, Dr. Fischray lives and works in Chicago as an attending hospitalist physician, caring directly for patients who are admitted to the hospital. Dr. Fischray is also known as Dr. No-No, and she is one of the co-hosts and a social media chair for Chocolate with the Side of Medicine. Good. Welcome, Dr. Fischray. We're excited to have you here. Next, we have Dr. Jackie Jones. She's born and raised in Chicago and is a proud graduate of the University of Alabama, where she obtained a Bachelor's of Arts in Business Administration and Healthcare Management. Prior to entering medical school, Dr. Jones worked as an academic advisor with Illinois State University, where she taught life skills to incoming athletes at the institution. Dr. Jones is also a proud member of Delta Sigma Theta Sorority Incorporated, where she provides continuous service to her community in addition to fulfilling her clinical duties as a family medicine physician. Dr. Jones is an alumna of the Loyola University Medical School, after which she matriculated to the Cook County Family Medicine Residency Program, where she eventually became chief resident for the class of 2019. After completion of her residency program, Dr. Jones is now based in Columbia, South Carolina, as a family medicine physician with Prisma Health, where she continues her passion for primary care, especially providing education to her patients about proper diabetes management. Dr. Jones is known as Amy Jo, MD, and is one of the co-hosts and public relations chair for the Chocolate with a Side of Medicine podcast. Welcome, Dr. Jones. We're excited to have you here as well.
Thank you.
And then sorry about that. Last but certainly not least is Dr. Christine DeReese, and she hails from Queens, New York, and she received her undergraduate education from Hofstra University, where she received a Bachelor's of Science in Biology. Dr. DeReese also obtained her MS in Public Health, specializing in community medicine from Brooklyn College, and afterwards was accepted to medical school at St. Matthew's University School of Medicine. After completion of her medical school studies, Dr. DeReese matched at the Cook County Family Medicine Residency Program in Chicago, Illinois, where she continued her commitment for providing comprehensive medical care to the underserved communities of Chicago. After graduation, Dr. DeReese continued her selfless work as a primary care physician with Novant Health in Winston-Salem, North Carolina, Dr. Doris is also known as Dr. Chris and is one of the co-hosts and financial liaison for the Chocolate with a Side of Medicine podcast. Please again help me enthusiastically welcome our doctors, which are known as Chocolate with a Side of Medicine, to our webinar today. Good afternoon, ladies.
Hello, good afternoon.
So today's conversation, last year we talked about COVID, and obviously that's still something that is important right now, but this webinar today is more about chronic illness. So would you all kind of talk to us, what does it mean to have a chronic illness, and what are some of the chronic illnesses that we need to be aware of?
I guess that definitely goes to one of the outpatient facilities. So that I see why Dr. No is looking at us like, ladies, do you know? So chronic disease management is probably one of the most important aspects that is managed in the outpatient setting, besides like routine health maintenance. So that can be actually a wide variety of things. Anything that is with you for more than 4 weeks, I think you consider chronic disease, right? So that can be the popular things: diabetes, hypertension, high cholesterol, but that could also be back pain, knee pain, shoulder pain, joint pain, rashes, lesions, things that have seemed to start and just not gone away. Those transition to what we call chronic, disease management. And so we are trying to make plans to figure out how, from a long-term standpoint, do we improve them or do we resolve them?
Thank you. I never thought about chronic illness being necessarily time, like more than 4 weeks. So that was an interesting piece of information. Because sometimes I think, especially as we age, we might think, oh, that's just what happens when you get older, you get back pain. It is what it is, right? But I don't think I ever conceptualized it as that could be chronic illness because it lasts for so long.
Yeah, and people come in and they don't realize it because they're like, fix my back. And sometimes the conversation is, well, I may not be able to fix your back, but let's kind of talk about all the things, especially in family medicine, right? So let's talk about all the things that may have gotten us to this point. So that's why it's nice for me in outpatient setting, because I get to know what you do currently, what you used to do, what you plan on doing, because sometimes that plays a role. I just recently had a conversation with a stylist who has been doing hair since she was 15. Well, she's not 15 anymore. She's now 50 and her back hurts, but that's knowing what she does. That's years of standing on that little tiny pad. Listen, we appreciate them for doing our hair, right? But they've been standing on that little tiny black pad behind that chair day in, day out. And when they're young, it's bad, it's head after head after head after head. And so they do it all day. And so the years, can add up, and now they have back pain. Well, for us, that's going to be a chronic disease because we need to figure out how to improve it. I probably can't undo 30 years of hairstyling, but we can figure out how to make it better.
Okay, I like that. Thank you.
I think
Dr.
chronic conditions. Oh, sorry.
Okay. No, I thought Dr. Doris was going to say something. Go right ahead.
I am definitely skipping Dr. Doris. You are very correct. Go ahead, Dr. Doris.
That's fine. Go ahead. You can go.
I was just going to say that chronic conditions, I think, are very important to talk about because these are the things that you're going to be seeing a doctor for repeatedly. So this isn't kind of like you saw your doctor one time, they gave you a pill and they can fix it. These are things that you're on a journey with your doctor, because your doctor is going to be there with you from when we diagnose it, how are we managing it? And some of these conditions, some of them people are going to be managing for the rest of their lives. So I think it's important to talk about them, because when people start talking about, oh, I really want a doctor that I can have that relationship with and a doctor that I trust, people who have chronic conditions really do feel that way, because you're kind of in the partnership with your doctor to try to help you manage these chronic things over time. And that's the beauty of primary care, honestly. So I completely agree with everything that Dr. Jones said. I co-sign.
So what I was going to say was, yes, we have the chronic diseases like your arthritis, your cardiovascular disease, heart disease, but I also wanted to mention mental health as well, because, depression, anxiety, that can just be a chronic thing that someone has to go through over time and has to be managed. So, I also wanted to highlight that mental health is also very important and also could be considered a chronic condition as well.
Yeah, go ahead, Dr. Fisher.
Yeah, so definitely, like what Dr. Jones said earlier, I kind of am not big on the chronic management in the hospital because what we usually see is the acute flare-ups of your chronic condition. So that's precisely why you're coming into the hospital, and that pretty much highlights why it's so important for us to have a relationship with our outpatient physicians to make sure that those chronic illnesses don't flare up and you have a couple of days stay in the hospital with me, because even though I love to see you guys, I very much would like you to stay out of the hospital and continue to be healthy and well. And I'm pretty sure the other 3/4 of this group have been doing that very well. So.
Absolutely. And thank you, Dr. Doris, for mentioning that, mental health is also a part of this as well. And I like how Dr. Thurston talked about journey. I wrote that word down, that, chronic disease is a journey, and it's something that may improve, but it may not necessarily go away, like you've talked about before. And understanding that the healthier you are, the more likely you are to stay out of the hospital, right? And to have those acute moments where the flare up is so bad that you need some immediate attention. So when it comes to women in particular, are there some chronic illnesses that are more prominent among women versus men? Things that we have to look out for?
So in addition to, I think that's a very interesting question, because I feel like because we are in this space, I feel like women of color in particular tend to have a lot of conditions that are more prevalent in compared to a lot of other groups. But I think in terms of women of color, the main things that really come up are some of the ones that Dr. Jones and Dr. Doris brought up, which is basically like high blood pressure, high cholesterol, because a key thing in terms of like, especially being a person of color, especially women in the community, we tend to internalize a lot of stress, and that can be stress from, the environment, socio-political things, just being Black in America. We tend to internalize a lot of this stress, but that stress manifests into physical symptoms and things that can really affect your health long term. So I think that that's probably one of the biggest things that I feel like I try to navigate with my patients, especially younger Black women who are trying to get pregnant, and especially older Black women that are still taking care of their kids and their grandkids. And it's difficult to navigate because that can affect your blood pressure, that can affect your eating habits, that affects everything. So I feel like that in particular is something I try my best to prioritize when I'm talking to my Black women in the office.
Absolutely.
I would agree with that. I think when I think about women in general, probably the separating women from men, the one thing I think about is just the many hats that women wear. So even though our roles have changed outside of the home, people tend to, whether they realize it or not, still have very traditional responsibilities inside their homes. So women tend to still be on the hook for meal planning and childcare and, financial planning, who gets paid, all these things. And then they're also trying to navigate, these very, important careers to them. And what happens in that case is that all the lifestyle things that I want you to have in place to prevent diabetes, to prevent hypertension, to prevent high cholesterol are really hard to implement and sustain because you feel like you can't do it all. And so, there's lots of empathy that's across the table when we're talking about things I think people need to do, because a lot of women are saying, well, I don't know where I'm gonna fit that in. Men tend to be like, well, tell my wife what you just told me so that she can get on board with these meals, right? And so that seems to be, one of the noticeable differences when I'm talking to women in my office, especially when it comes to chronic disease management.
Yeah, I think that's so important because I work as a psychologist. I am a psychologist. And anytime I talk to people, women in particular, about self-care and about making time for those things that help us to reduce our stress and things like that, that is the common answer that I get. Well, where am I supposed to fit that in? I don't have time to do that. And so, but when you start connecting, again, that mental health piece, that stress piece to your physical health, it becomes a better conversation to say, well, the reason you have so many headaches or the reason that you're feeling some of the things you're feeling in your body is because you're not managing the stress, right? And so that's very important. You brought up high blood pressure and, hypertension, high cholesterol. Can we talk about that a little bit? What kind of things cause high blood pressure if we start there?
Oh gosh.
Oh, that's such an interesting question.
I was just gonna say, like what's interesting is that whenever I have a patient come to my office and I take their blood pressure and it's high, then I like to start by talking to them about the most broad list of possibilities that it could be. It could be anything as simple as, so do you smoke? Did you have a cigarette before you came in here? Or do you drink coffee? Or are you stressed? Or do you have a lot of salt in your diet? So like the list goes on and on. And from talking to the patient, when you get to know more about their life, and you're like, okay, I get it. You do have a lot of salt in your diet. You are stressed. You did have coffee. Like you kind of, the list compiles, the list compiles very quickly sometimes if you're not aware that like your typical habits are really leading you down this path. But yeah, it can be caused by a multitude of things.
So what Dr. Thurston gets to, I'm
Wait.
sorry, what Dr. Thurston gets to is how you get a high number in the clinic, right? That's not quite the same as what causes hypertension. So the dysfunction of your system that causes hypertension is complicated because it's got all kind of layers. It's environment, it's genetics, it's food, it's stress, it's all these things. So there's no one thing, right? And so I have to tell that to particularly Black people, because when they come in and their blood pressure is high and maybe mom, dad's blood pressure is high, grandma's blood pressure is high, they're like, well, it's just a matter of time for it happened to me. I see I've arrived. Like, no, like genetics in itself does not have to be the leading factor. So we all have some genetics. Now it depends on how deep you want to go. Like people talk about, like the slave trade, body's ability to maintain sodium and some of that genetic component being a survivable trait to get to where we are. And if it was a survivable trait, that means we pass it along. But now in modern times, do we need that trait anymore? Probably not. So there may be some genetics to it. But then there's also environment, where we live. Do you have sidewalks, right? Do you have a park? Can you exercise? Like that matters. What is there to eat in your environment? I remember when I lived on the west side of Chicago, if I got off at 2 a.m, don't ask me why I was getting off at 2 a.m, it's not the point. But what was there was McDonald's was open, Harold's Chicken was open. I'm not against Harold's Chicken. I will go. But, what do you have access to? And then what's happened to you over the years? Did you get diabetes first? Did diabetes make your blood pressure dysfunctional? So it's no one way to get hypertension. There's all kind of things that are in there.
Actually, that's what I was going to say when Dr. Thurston talked about, how much sodium may or may not be in your diet. I was going to do it teasingly, but that's exactly where I was going. As you talked about the chicken, I was going to say, but we need seasoning in our food, right? We need our food to taste right. And what do you mean I can't have, this seasoning or that seasoning, or that slap your mama is what's up, or the Cajun seasoning, right? And so, like, how do we pay attention to things like, my blood pressure was elevated, or maybe I have been diagnosed with hypertension. How do I, have the same quality of food and the taste that I want while maintaining, good sodium levels and things like that?
Well, I'm sorry. Go ahead, Christine.
Well, I was going to say that's a really good point. I mean, I think the thing is we learn a lot about how we eat by how we grew up, the things that we know. So we cook according to what we know. And then you go to the doctor and they're like, oh, you can't eat that. You shouldn't eat that because this is going to increase your risk of this and increase your risk of that. And then you're like, well, what am I supposed to do? Right. But the thing is that you shouldn't have so much sodium in your diet. And I think a big portion too is that people need to be active. And I think a lot of people have adopted a sedentary lifestyle, and all of that contributes to your blood pressure being elevated. And also obesity, that's a major risk factor as well. And we just need to pay more attention to that, trying to exercise more, try to adopt healthy eating habits to help decrease our risk of high blood pressure.
sometimes, you know, your genetics is your genetics, but, you know, there are lifestyle things that you can do to help decrease your risk as well.
Go right ahead.
So kind of going off that point, I know that, you know, with a little Western diet, we have a lot of added extra sodium that's added to your food. So when I see patients, typically they're saying, oh, you know, they come in for like high blood pressure, or we're sent in from the clinic for, you know, elevated pressures. And they're wondering, well, you know, what did I do wrong? Like, I'm not adding any extra salt to my food. And I'm like, well, you know, you have to look at the sodium content that's on the nutritional facts on the foods that you're eating. Because if you don't look, you can actually get a lot of like almost a couple days worth of sodium in one meal if you're not paying attention to how much salt is in that one meal. So that's, you know, not adding salt to your food is one thing, but then you also have to see kind of how much salt is already in the foods that you're eating, because that will have a humongous impact on your blood pressure if you're not very careful. And then kind of with that, so, you know, people also come into me and they're saying, well, you know, I've been really good. Like my blood pressure's been high. You know, I've been like, you know, doing all these diets and stuff. And I'm like, well, you know, there's actually a lot of research and evidence that's showing that vegan or vegetarian-based diets have actually been really good at helping control your blood pressure. So there's actually been a really big movement, and I've been seeing all the restaurants and like the that kind of are what's the word? They're kind of going towards like the vegetarian diet, veggie-based lifestyle. And that's actually been shown to help actually keep your blood pressures and a lot of other chronic conditions in check, because a lot of those extra salts and the extra preservatives that you have in your food, they're not adding to your pressures long-term, and that can actually be a really good way to keep your blood pressure. Some people can actually get off their medications altogether with following a vegan or vegetarian-based diet. So that's typically what we like to recommend. You know, there's keto, there's paleo, there's all the other paleos out there. But the one thing is for sure is that a vegetarian-based diet is actually very good, and we should be recommending that more to our patients.
Not to go, oh, sorry, Amy Jo, you're first.
So in my clinic, I do a lot of food education, right? And I, without fail, ask every single person for a 24-hour recall. Now, one, y'all can't ever recall it, right? And so if you can't remember what you ate yesterday, there's no way for you to remember what you ate last Monday or the Monday before last. So when I have people sitting in front of me saying, I just don't understand why my blood pressure is high, I can't lose no weight, I mean, I'm eating healthy, I don't believe you. Listen, no offense, I just don't believe you, because we don't work hard enough for our food, right? I tell people, ask 10 grandmas what they cooked last year for Thanksgiving. They would name it. Oh, I made turnips and collards, and oh, my favorite grandchild was coming home. He loves this pineapple 7-Up cake. I made it for him. I did this, I did that, because she worked for us. She got the last macaroni and cheese box, and then somebody had the nerve to take that sweet potato. She had to go down the street to get the next one. All this stuff happened. It is in her brain. Like it's fused in there. Ask that same grandma, what did you eat yesterday? And it'll be, what was yesterday? Oh, wait, did I go to church? No, I had a sandwich. No, maybe not. So people don't remember what they eat, right? So that's the first thing. There's a lot of confusion. When it speaks specifically to the sodium, so the answer to the question is, when people ask me what you should do, first you should cook it. Because the only reason why we're talking about sodium content is because we're talking about processed foods. And whether you are plant-based or a complete carnivore, if those food choices came from something processed, meaning you did not get it on the outside of the grocery store, you did not select it in its original form, then it's gonna come with some sodium because it has to be preserved, right? When you come to my house, I don't make healthy mac and cheese. I got the butter out. I don't use that butter. That butter probably been in there since the last time you were here, but I use the real butter. I used all the creams. I use all the cheese. Why? Because I want you to come back and eat my food. Well, in a restaurant or a frozen food section or a fast food chain, it has to taste good because you got to come back, which means they've done things to it. If the only salt you were getting in your diet was from you seasoning your meat before you put it on the grill or before you put it in the oven, that is not the kind of sodium intake that is going to do it. And so I have to correct Black people all the time because they're like, oh, you just want my food to taste like cardboard. No, I don't. You can season your chicken as much as you want to, as long as you skip the Chick-fil-A line. right? You can give up
Yeah.
Chick-fil-A and you can have all the salt you want on that drumstick that you make at home, but you cannot have both. The sodium is in the processed foods. Now, I'm biased like Dr. Fishray. I believe in a plant-based diet, and I believe in a vegan diet if you can tolerate it, but you can be a plant-based and vegan junk food eater. And if your plant-based or your vegan food is coming from the frozen section out, and you too will have a sodium problem.
I'm gonna add I'm gonna reel it in to make it a little more realistic here. And I know that Dr. Fishray and Dr. Jones are feeding you guys these plant-based diets, vegetarian, vegan. Don't get me wrong, it's super healthy. We all worked on the south side of Chicago, and we all know the patients that we used to see and probably still see to this day. There's a lot of them where if you even say some of them, even saying a vegetarian diet almost seems so unattainable that some of them they feel so overwhelmed, they won't even try. They're like, vegetarian diet. They're like, doc, that's like, because it's something that's it's so outside of the box from what their day-to-day life looks like, that it's hard for them to even figure out how to attain that, especially if they're in a food desert. So I usually like to meet patients where they're at. And I'm like, okay. And I agree with Dr. Jones. The food diary is great. I like to meet them where they're at and see if we can make some changes here or there. The biggest, easiest change that most people, especially Black men, can probably do is to minimize the amount of pork that they are consuming if they eat pork. Pork is by far the saltiest meat that you are going to find. So if you can just minimize the amount of pork chops, bacon, ham, depending on how their diet looks at their baseline, little changes like that can actually have a really good result, in addition to, exercise and things like and vegetables and such. So sometimes you have to meet the patient where they're at and give them a realistic goal before I hit them with this vegetarian diet, they're gonna be like, what? Not doing that.
And Dr. Thurston brings up an interesting point, which I want y'all to hear, right? We've all got really different approaches to what we're giving. And because I'll get patients saying, well, I just don't know who to believe because, this doctor telling me that, this doctor telling me that. But at the baseline is really the same thing. You've got to lower your sodium content. It cannot be processed foods. I try to meet people where they are, but I have learned if I go down there with you, then you stay down there. So I'm like, okay, we can't stay down here. We gotta move back up. But processed foods really are the issue. And so whether you heard, oh, well, I can eat chicken and fish, but my doctor said I just had to take out pork. Well, then I went to this new doctor. Now she's telling me to go plant-based, where I went to this doctor and they told me I can only eat fish. I'm so confused. I guess I'll go to McDonald's. Nobody said McDonald's in that. In all the conversations that you heard, processed food was still not on the table. So even if you're like, I am not a plant-based eater, I need meat, it still has got to be a whole food diet, meaning I picked the food up in its original form and I decided how I was going to prepare it, and I decided how I was going to eat it. And so it gives you back the control.
I like that. So one of the biggest takeaways for me right there, again, if you look at it in its simplest form, is to cut out processed food right there, right off the beginning, cut that out. And even that alone makes a big difference. So then maybe after that, the next step could be, okay, I'm going to cut out pork that I cook at home, right? And then maybe sort of walk it back. And for some people, that might be an easier option versus going from eating, Chick-fil-A, McDonald's, Burger King to vegan. That might be too big of a jump. But to just start by saying, okay, I'm going to cut those things out, or at the very least, it's a treat that I allow myself once a month or something like that. But making these incremental changes to walk back to possibly vegan. Would that be a fair way to kind of look at it too? Yeah, and to be honest with you, go ahead, Dr. Fishray.
No, just so as a personal side note, so I'm like on a more pescatarian, vegetarian based diet. I already know I can't go full vegan because I love cheese too much. So that's never going to be an option for me. But the thing is that, you like exactly what you said, you kind of look, as long as you cut out your processed foods and you're cooking more of your meals at home, when you have the time that allows you to do that, you can see kind of how much, seasoning and, salt you're adding to your food. And that actually can be enough to kind of, solidify your more healthy lifestyle, make it more of a habit. So I do allow, myself to go out and have like a meat maybe once or twice a month. But for the most part, most of my meals are either pescatarian with like some type of fish or vegetarian, and that has done, and it's worked very well for me. So it works.
That's awesome. That is awesome. So what others, if we stay with looking at hypertension and high blood pressure, what other health problems are associated with high blood pressure or having hypertension?
Oh, I got this. So the issue with high blood pressure, so your cardiovascular system affects so many other systems within your body. It virtually affects everything. So if your blood pressure is high enough, the one thing that definitely comes to mind is that you can have a stroke. So a stroke is essentially you have decreased blood flow to your brain, and parts of your brain actually shut down, and that can manifest as different neurological symptoms on exam. So, we talk about FAST, which is like the facial droopness, the slurred speech, the weakness in one arm or one leg, or different like numbness or tingling that's, more that's present on exam that wasn't there before. Those are like the biggest symptoms that we typically see for a stroke. And, I've seen people come into the department with like pressures in like the 240s. And I was like, is that possible? But it does happen. And, that's definitely when your blood pressure is not well controlled, that is an extreme example of what can happen. In addition, high blood pressure can also affect your kidneys. So we were talking about kind of chronic illnesses that are more common among people among color, and chronic kidney disease is definitely up there. So if you have really high blood pressure that goes on for too long, it can actually cause your kidneys, well, technically not to shut down, but to not function at their 100%. And that can actually lead to, when the kidney disease progresses, it can, get to stage 4. And then eventually with stage 5 is typically where you're kind of planning for dialysis. And that is something that we definitely try to avoid by making sure your blood pressure is in check. Diabetes is another culprit. That is Dr. Jones's baby. So I will let her talk about that. But essentially those things can definitely lead to, CKD, strokes. Heart attacks are also another big thing that can lead to uncontrolled blood pressure. Your heart is essentially a humongous muscle in your body. So if you're overworking that muscle by, so when your arteries, so again, it's all interconnected, but when your muscle is kind of working overtime for so long, it eventually is going to tire out, and that can lead to, impaired function later on down the line. So I could probably go, this could be a whole 2-hour talk by itself, but those are like 3 of the main systems that your blood pressure can affect that we really try to get into control in an outpatient setting before you end up in the hospital on the stroke unit or elsewhere. So.
Wow. So yeah, it is all interconnected. And I think sometimes we forget that, like we sort of see things in silos, like, this thing is over here by itself and this thing is over here by itself, but it's all really so interconnected, and one system then affects another, right?
Right. Yeah.
So what about diabetes? You brought that up, and you said that was Dr. Jones' baby, if I remember correctly. So let's dive into that one, because I know that's a pretty big topic and a big problem in the Black community. So let's talk about diabetes. What is it? What causes it? Let's go.
If you let her, Dr. Jones will talk for an entire lecture about diabetes. If you let her.
Look, I'm stretching. It's okay.
She's like, oh, ready. This is me all day.
First, I think diabetes as a disease adopted me. I did not adopt it. It just keeps falling in my lap. So, and I am in the South. I am in the deep South, and so. Even though I've seen a lot of diabetes because, of my training in Chicago and working in Inglewood and being on the west side of Chicago, I've seen it a little bit differently here. So I feel like when I was in Chicago, I was trained in underserved, people didn't have enough insurance or didn't have any insurance or couldn't afford it. Here it's a little bit, maybe even more heartbreaking, because these are well-insured people of color that are just kind of folding under the disease process. So what is diabetes? So, okay, first of all, there are 2 types. For the sake of this discussion, we're going to keep it to the one of the 2, right? There's type 1 diabetes. It's an autoimmune disease. It's very different then type 2. And people need to know that, because often children get type 1 because it happens earlier, and families are trying to manage them like they had type 2 disease, type 2 diabetes, like it's grandma's diabetes. Grandma's diabetes, which was probably type 2, is not the same as this baby's diabetes, which is type 1. Type 1, it attacks your pancreas, so you don't make insulin. Insulin is a key to allow you to put sugar in cells. Sugar is fuel, right? And so that's type 1. Move it off the table. That's the end of type 1. Let's talk about type 2, because type 2 is what really impacts mostly adults and people who are being impacted in our communities. Type 2 diabetes is actually a little bit more complicated than that. It is a dysfunction of the whole system. It is a system that has become so overrun with fats and sugars that you no longer know how to get all the sugar that's in the system into the cells, right? And when sugar gets to hang out any place but inside of your cell, it does damage. It does damage to the eyes. It can cause blindness. It does damage to the vessels. It can cause strokes, heart attacks, kidney disease. It does damage to the kidneys themselves. It likes to mess with the smallest things. So I used to tell men and women, stretch your hands and your toes out. Anything furthest away from your heart is at risk. So that's fingers, toes, penises, and nose, right? And so if you got your...
Made Dr. Thurston laugh.
It's true. Listen, we go all the way in my clinic, right? You need to know, right?
I've never known that. I'm going to start using that in the office too. What'd you say? Fingers, toes, penises, and noses? Dr.
Yeah.
Jones.
It rhymes.
So it can damage the nerves, right? Nerves in your fingers. And you hear grandma saying, everything feels so slick to me, or why is it burning? Why is it tingling? Because it's messing with the nerves in your fingers and your toes. Men, they sneak in, and like, hey, my wife about to divorce me, because women like sex too, right? And so women be putting pressure. I know, because I talk to your husbands, y'all be putting this pressure on and be like, if you get here tomorrow and you are not ready, we're going to have some problems. In the meantime, they don't know what's going on. They don't realize it's their diabetes. And so sugars get too high. They linger. And when they linger, they do damage. That's the basics of type 2 diabetes. Now, how we get there is complicated. It's almost like hypertension. There is a genetic component to it, but it's also environmental. And generally, I tell people type 2 diabetes is a disease of the diet. If you fix the diet, you can fix the diabetes, or what I should say, because I've had to correct this because my patients learn me every day, is that you can have diet controlled diabetes, right? So I had to stop saying you can get rid of diabetes, because some people come in and say, well, I decided today I was getting rid of diabetes. I was in church on Sunday and I declared healing and I'm done with diabetes. And I'm like, but where is your medicine? They're like, I'm done. Like, that's not how it works. Right? I mean that with a good diet, you can fix it. Diabetes can be varied, right? We've got people who are mildly diabetic, right? A1C is how we check for diabetes. 6.5 on an A1C test and up counts as diabetes. If you have ever had a 6.5 in your life, then I want you to think of yourself as someone who has diabetes, and maybe it's well controlled. Maybe you got your life all the way together. Your waist is snatched. You feel so good. You never saw that 6.5 again. That's great. You are a wonderfully controlled diabetic. But anybody that's crossed over to a 6.5 and higher, that is diabetes. The A1C is important to know because it is not just a right now test. And A1C looks at your blood sugars over the past 3 months. So we have a way of seeing what you've been doing over the past 3 months, because sugar is sticky, and sticky things stick to red blood cells. And so when I am looking at your A1C, I am trying to see how much sugar is stuck to that poor little red blood cell. And depending on how concentrated it is, I know what you've been doing. Because people come in and they say, you know what, I had a birthday party the night before I came in for these labs and I had cake. That may be great. Some of that cake may be stuck on there, but some cake from last month is on there too, and the month before that. So we got lots of cake stuck on the red blood cell. That's what tells me what it is. How you treat it is complicated. Sometimes you just need oral medications, couple pills, call it a day. Metformin is the most common one. People have got lots of thoughts and feelings about metformin. I do too. My thought is still you need to take it. Or it can be more complicated, right? Your A1C is so high that I feel an urgency. And when I feel an urgency and I've got a lot of tolerance, then I may have to put you on insulin depending on how that is. So, those are really the basics of diabetes. Why it's important is because we lose a lot of eyesight to diabetes. I have young people, 30s, 40s, 50s, that are legally blind because of diabetes. You can lose your kidneys. And these aren't old people, right? Like, and not that we want older people to get it, but I think we kind of have this feeling like, well, if I'm young enough, I'll endure. But we have people that have lost their kidneys. We have amputated feet. We have lost vision. We have seen strokes. We have seen heart attacks. And these can be in people as early as 30 if we don't fix it.
I'm gonna dive in here really quick. Oh, my bad. Go ahead,
I'm just saying, I definitely have admitted many people in their 30s with literally all the complications from diabetes. So they were on dialysis, they were legally blind, they've had a toe, a foot, someone actually had a, bilateral BKA or below the knee amputations. They were not much older than me, and they were in the hospital for something else. And I'm just like, wow. Yeah. That's the damage that diabetes can do when it's not in control. So, yeah.
I'm going to take a quick pivot, still on diabetes, of course, but I'm going to expand a little bit on something that Dr. Jones was talking about. So there is one thing I really want to emphasize here that I feel like a lot of people either they don't know or they don't remember this. So when we're talking about your diet and we're talking about diabetes, yeah, there's these sugary sweets that everybody's aware of, but one of the main culprits for diabetes is actually starch and carbs. Because when you eat these starches, when you eat these carbs inside of your body, they turn into sugar. So I'm talking about bread, pasta, rice, potatoes, all these heavy starches. Once you ingest them inside of your body, they turn into a form of sugar. And then that can also raise your A1C. So every now and then I'll run a blood test, the A1C number is really high. And the patients will say, oh, but doc, I don't eat sweets. I don't even like desserts, because that might not be where the sugar is coming from. And then I'm like, well, walk me through your day. Tell me about your plate you ate last night. They're like, oh, well, last night, I had like a big old plate of spaghetti, pasta, with the side of potatoes or corn or something. And when you have these meals and you have more than one starch and large portions of starches, that'll raise your A1C fast. And for a lot of people, it's hard, especially people in southern states. I know because, I'm from the South and I have a lot of southern cousins, and they love the starch, especially like, the mac and cheese, the biscuits, it's a staple, but when you have all that starch, and if you pair it with also eating sugary things, you're doing double duty on these sugars in your body. And then when we decide to screen you or run the A1C test, you're like, how did we get here? So I think that's something that's really important to pinpoint there.
And the fats. They come together, right?
And
because the fats clog your system, right? The fats, mess your liver up. Your liver produces your hormones, right? And to have a healthy hormone production, you need to have a liver that's clear. And so when you are consuming, most time the consumption of those starches come with the fats, right? It's never just spaghetti. It's spaghetti casserole that is covered in 3 layers of cheese, with garlic bread that's covered in butter, with all these things. They always get paired together. And listen, I love a good spaghetti with the best of them. I've been trying to eat spaghetti for like the past 2 months. Like I've been posting on my Facebook page everywhere, like I miss spaghetti. But you cannot have all of that at the same time. And then you wash it down with the sweet tea down here in South Carolina, or you wash down with a Sprite, pop, soda, whatever you call it, and it just comes together to really make it complicated. So yeah. What it's not though, if I can say that, because this kills me in the office. What it's really not, it's really not your fruits. Right. And you're just gonna have to trust me on that. Right. I get people coming all the time saying, oh, doc, I had, mac and cheese last night and, baked chicken. And I had an apple for dessert, and I had a sweet tea, and my blood sugar was up. They told me not to eat them apples. I could just throw the whole computer away, right? Just throw it all away. Like, that's not it. Right. And so if you were eating a very clean meal, if you had baked chicken, and can we swap out the spaghetti for maybe a baked sweet potato without the butter and the sugar and all the stuff on it? You can still have the sweet potato. And we had some vegetables, and then you decided to have a piece of fruit for your dessert. I promise you, if you checked your blood sugars, they would not spike the same way. Or if you now have the continuous glucose monitors that I love, it would not be the same way. And why do I know? It's because I got my hands on the continuous glucose monitor and I stuck it on there, and y'all ate everything. Some moments I was very happy about myself, and other moments I was like, you have got to be kidding me. I thought I was going to be diabetic by the end of the 2 weeks, but you see what they do. And so the fats also matter.
So Dr. Chris is an unofficial spokesperson for this monitor, so I'm going to let her talk about that.
Her getting excited. I was going to say, I feel like we need to let her in there.
I think she's muted.
I had it, I still have mine. Sometimes I forget to check it, but I realized that it does spike if I had some starchy meal, and I knew that, and I do it. I'm like, oh, that's why it was so high, you know? So it's really, I think it's great. I wish insurance companies would really cover it a lot for the patients, because I think it really helps them and shows them that, you know, we tell them what things are going to affect their glucose, and they're like, yeah, okay. But when you actually see it, you check it in real time, it really does change your behaviors. So I really wish that insurance companies would cover it, but yeah.
Yeah, I saw that. I don't know. I mean, it's Medicare. I mean, Medicaid. Is so the honest answer is that they're expensive. They're brand new, they're expensive, and companies want their money, right? They are not ready to take the steep discount that Medicare and Medicaid require when you are, you know, getting something from them. And so Medicare and Medicaid does not pay health systems well, right? They pay okay, but they don't pay health systems well. And so when you're talking about private companies that have made these cool toys, they want all of their money for as long as they're going to get it. And so that's why it is not covered.
Two questions. Oh, go ahead, Dr. Fisher.
Oh no, I'll just put it in the chat. So I believe the Dexicon, like out of pocket, is about 900. So that's, I mean, that's, and I think the cost for a regular glucose monitor is about 100 to 150, I believe. Is that right?
You can get one at, no, girl. You can get one at, you can get one at Walmart for $9, right? You can get you a basic glucometer, and you can get the strips and everything. So the glucometers have become very cheap. They're not that expensive anymore. And so you can find places where you can get them. Not to be confused with the fancy ones, but the glucometer is very inexpensive. But you know, it doesn't give you all the information. And so I think you can learn from the continuous glucose monitor what's really happening, right? So to learn the same information from pricking your finger means you got to be committed to pricking it, and it hurts, right? People don't like to do it. The continuous monitor, as long as you're checking it every 6 to 8 hours, will give you a 24-hour window of what your blood sugars look like. And so you can see exactly what happened 30 minutes after you ate that cheeseburger. You can see it spike, actually, you know, because you may check your blood sugars and you say, oh, well, it's not so bad, it's 220, you know, maybe I'm not doing so bad. But what you didn't see is that it actually went up to 310. And by the time you checked it, it was coming down, and you caught it at 220. And while that is high, it doesn't tell the whole story. And so there's lots of information to be learned, but you know, it's a cost thing. It's not a science thing. It's a cost thing. I would love for everybody to learn from a continuous glucose monitor.
Question that came to mind for me is, how does exercise play into this? Because you talked a lot about how the sugar sticks to the red blood cells, excuse me, and how carbohydrates will turn to sugar, which then sticks to your red blood cells. So how does exercise play a role in this? Because if the sugar's sticky, it's going to be sticky anyway, right? But talk to us about how exercise makes a difference, even as you're eating that. And then I'll also ask you to talk about, like, how does moderation play in there? So, you know, for those that you talked about living in the South, am I never supposed to have, you know, peach cobbler again, or sweet tea, or, you know, grandma's Sprite cake, right? So will you talk to us about exercise, and then how does moderation play a role in this?
So exercise is interesting because we got to go back to the whole insulin, right? Remember how we talked about insulin was a key that unlocks cells, that you could get the energy into the cells, get the sugar into the cells. Exercising muscle does not need a key. That is why exercise is so important for diabetes, because when you are exercising muscle, because, you know, we're still primitive, right? We're still running for bears at our baseline. When you are running from a bear, we do not have time to find a key. You ever been in a hurry looking for your keys? You don't have time for that. So when you are exercising, you do not need a key to get sugar into the muscle cells, right? And so when you're exercising, you will freely burn glucose because your muscles are using it. Now there's a catch. If you are so full of sugar, you're so sweet, right? Just sweet on the inside and out, right? If you are so full of sugar, then you may not get that impact right away because you're going to be dumping all these stores of sugar that you have. But at some point you will even out. And when you exercise, you will burn off some of that extra sugar that you have in the system. And that's the importance of exercise. And so exercise is going to build muscle, build muscle tone. The more muscle you have means that every time you exercise, that muscle is going to use up some of the extra glucose that you have hanging around. Mm-hmm. Moderation is different. I think you're going to get a different opinion from each one of us. I don't know what y'all mean when you say moderation, right? Moderation, in my experience, means, I used to have 2 Sprites every day, and now I only have 1. I am in moderation, right? And that's not moderation, right? That's still too much. And so it really, I think moderation depends on the food. If you were asking me about processed meats, I would tell you there is no room for moderation because processed meats cause cancer. So I don't know how to moderately expose you to cancer. If you were asking me about, simple sugars when your diabetes is not controlled, I really don't know how to offer you moderation in that. If you're talking about, I really do love potatoes, and at least once a week, I gotta have some roasted red potatoes with my meal. Okay, that's fine. I'm not here to, fine, enjoy it by all means. But the things that really do a lot of damage, moderation is probably not my goal. I would sooner watch you take your time and learn how to decrease the consumption of them. I'm not in a hurry, but I don't know that I sign off on moderation for all foods.
I am pro moderation. So, but I do not disagree with what Dr. Jones just said, because we can touch and agree with a little, we touch and agree. Part of, my whole mantra is meeting the patients where they're at. So for moderation, the main thing that comes to mind for me is that when I start talking to my patients about their diets, I'm a really big visual doctor. I draw things for my patients all the time. I draw a plate for them. Like, let's assume this is your plate. Okay. 1/4 of your plate and no larger than 1/4, 1 little quarter of your plate. That is the largest amount I want any type of starch to be on your plate for dinner. As in, you have the other 3/4 of this plate to have your protein, whatever meat you pick, hopefully not pork, veggies, you have this other 3/4 of this plate to play with your veggies and your protein. But the largest amount of starch that you need to have for dinner needs to fit in that 1/4 of a plate. And don't pack it. I tell them all the time, I'm like, don't pack it sky high now. Don't pack it sky high. That's not the cheat code. I'm saying a typical normal portion. And you have to go over this. And I particularly encounter this problem with men because men tend to have their portion sizes in their heads are just so off. And I'm like, let's talk about portion sizes. Like, because for them, they're like, oh, you mean like 1 scoop of mac and cheese? I'm like, well, it depends on what you're scooping with, right? So let's talk about portion sizes. And that's usually something I can give them. And then they have a better understanding of, okay, this is what this is supposed to look like. In my perfect plate, I want 1/4 to be your starch. Maybe we'll call it mac and cheese. The other 1/4 to be your meat. And I want that other half to be veggies. That's my perfect plate. That other half can be veggies, and that can be a salad and some green beans. That can be some broccoli, or the whole half of the plate is broccoli. That's my perfect plate for someone who can't completely eliminate the starch, in my opinion.
For
Is
these
that it?
salads, you can't be drowning them in ranch and blue cheese. Like, it's more dressing than it is the salad. That doesn't count. So we need to bring it back. Use balsamic vinegar or some type of oil-based dressing. I've seen people pour like literally a cup full of ranch dressing over this. I'm like, sir, what are you doing? That's way too much. But yeah.
So is that, Dr. Thurston, I like how you talk about, the quartering the plate. Is that a good recommendation for the holidays coming up? Because, we've got Thanksgiving here in what, 3 weeks, and then Christmas a month after that.
You know what? This question that you're asking me actually leads into something that you had already mentioned, and I'm sorry that we haven't touched on it. So listen, these numbers that we see, this A1C and all this, that we're talking about, that usually does not come from your Thanksgiving dinner or your Christmas dinner. That's not how it works. I want you guys to enjoy Thanksgiving, enjoy Christmas. You're with your family, fellowshipping, enjoy it. But that number usually comes from eating like it's Thanksgiving every single day. There are some patients that have like smothered pork chops, mac and cheese, yams. That's how they eat every day. Some of my cousins in Georgia, that's how they eat every day. And that's what's going to get you into trouble. So when the holidays roll around, I say enjoy yourself, that's fine. But when the holiday ends, that's also when your splurge needs to end.
Yeah.
You know what I mean?
I completely agree with that. Like, I typically do not have any restrictions for the holiday. The whole point of having this healthy lifestyle is to think of those foods as things you enjoy. You're breaking bread with family. You're enjoying this moment, especially, in the middle of the pandemic. So any opportunity that you can spend safely with friends, if that's done over a meal, I do not want anybody sitting there thinking, well, Dr. Jones said I can't have this, so I guess I have to pass it. That's not a conversation you need to have at the dinner table during the holiday. But if the issue is, if there is no established lifestyle, then how do you know how to get back? What happens is people just don't know, right? This is what they're eating, right? There's no difference between Thanksgiving and Christmas and New Year's to any other day. And so the Thanksgiving meals turn into the next 2 weeks until they get back to, the fast food. And so I want you to know that you're not eating how you normally eat, but when you're done with the holiday, and whether that's the day and the day after, because people tend to stay, around for family, I want you to come back home to a safe space. And if the safe space is not established, then, well, we're just holidaying it all 365, right? And so that's the problem.
Yeah, we have a question from the chat, but go ahead, Dr. Dries.
I was just going to say, I always remind my patients when we talk about the holidays, I tell them it's one day. So fine, you do that one day, but that is not what you're supposed to do every day of the rest of your life. Like, what we talk about is lifestyle changes. Like everyone was saying, like, we have to make changes to continue to stay healthy, right? And I also definitely talk to my patients about portion sizes as well. And like Dr. Thurston definitely laid out, like, that is what your plate should look like, right? And I try to tell my patients, like, you're going to be hungry because you're not used to this, but you have to train your stomach, and your stomach is going to be okay. Like, you're not going to starve to death because you decrease your portion size. Over time, you'll realize and you'll see that you don't need to eat that much, right? And then you're full with even just eating a little bit, right? And you'll feel better. You'll have more energy. Like, so many patients that I've talked to, I tell them, hey, I try to a lot of times meet them where they're at. And if they eat a lot of fast foods, I'm like, or drink sodas, I'm like, cut that out. You're going to lose weight just by doing that, and they start telling me, they come back, they're like, you know what? I feel so much better. I have more energy. I'm losing weight. And it's kind of like we start off doing just small changes and they already see the difference.
Yeah, absolutely. And again, I think looking at it from the very beginning, you all called it a journey. And if you look at it as a journey, not necessarily like a sprint or a diet that you're going to do for a week and then stop. If it's a journey, then you're eating today for who you will be 10 years from now, 20 years from now, 30 years from now. And that feels different than eating for just in the moment, right?
Yep.
The question that came in from the Q&A says, I've been told that it's important to exercise for at least 10 minutes after each meal to help manage glucose. What is your reaction to this statement?
Sure. I mean, I don't know that to manage. I think you still gotta, if you had Chick-fil-A, you cannot outwork a bad diet, right? And so I don't want to, I'm trying to unpair us from this idea that, oh, splurge a little, exercise a little, they cancel each other out. Like there are foods you can't cancel out with a 10-minute or an hour exercise after that meal. And so if you are trying to get your 30 minutes, right? And so I think we talked about this last year, like the recommendation is 30 minutes of moderate to strenuous cardiovascular activity 5 days a week. Some people do not have a set 30 minutes, but they pause in their day to eat a meal, right? And so if after every meal, you getting your 10 minutes for breakfast, 10 minutes for lunch, 10 minutes for dinner, get you your 30 minutes, will that contribute to lower blood sugar? Sure, absolutely.
I'll take it.
So yeah,
I'll take that 30.
I'm not turning down 10 minutes of exercise. Yes, please give it to us. We'd love to have it. I still want to see your food journal though.
Yeah.
I want to see what that meal was.
The thing is definitely like 80% of the changes you see on your body don't actually come from the gym, they come from your diet. So if you're working out in goals to, lower your blood sugar or lower your blood pressure, but you still eat, I don't know, Chick-fil-A, McDonald's, whatever, every day of the week, then you're not going to see anything. You can actually get worse. But you need to make sure that you're exercising. Your exercise is supposed to complement your diet. It's not supposed to replace it. So that's the biggest thing. When I do have a chance to counsel people in the hospital, that's usually what I tell them, that you cannot, that is the mantra, you cannot outwork a bad diet.
Yeah, I was just going to say, all of them know that I work out a lot, but like, even though I work out about 4 times a week, but if my diet is not up to par, it doesn't matter what I do. I can work out hard and train, but I still can't get to those goals. Or my goal is to have a really flat stomach. But the problem is I do have an addiction to some carbs. So that's gonna make it hard. And like Dr. Fisher said, you really have to adopt that healthy eating. You can't just think that just exercising is just going to cancel it out. No, you have to eat to maintain it, because if not, then it's like you're a hamster running on a wheel. You're not going to really get anywhere.
You know why that's important? Because when you don't understand it, it builds frustration. Mm-hmm. And frustration is how you end up just throw it all away, right? And the reason we kind of push it home is because we need people to understand the relationship of food versus exercise, what they do to your body. There's nothing worse. And I feel for people who are like, you told me to go home and you told me to work on it, and I've been putting in lots of work. It's maybe a bad plan, but it was a lot of work, right? It doesn't matter if the plan wasn't exactly correct, but this person feels like they've been conscious to it. They've been working hard. Yeah, I may have had a lemonade and a burger, but I worked out. I did all this kind of stuff because you told me to get focused and to get back to my office and step on the scale, and they don't see the weight loss. They don't see anything. I know that they're in danger of saying, you know what, just forget this. I am going to get some chicken wings right now, because why did I do all of it? And so the reason why it's important for people to know is that we know that it's hard work. Even if it isn't the right work, hard work is hard work, and it builds frustration if you do not see the results. And so trying to get people to understand what gets you results is very important.
Thank you. And that actually leads to the next question that popped up in the Q&A. So I don't know if you knew that, but that was an amazing segue to this question. And the question says, how long does it take for your body to adjust to the adjustments in caloric intake from the small changes that you make and reducing the carbs? So how long does it take to see these results? Dr. Fisher talked about that, 80% of what we see in our body is about what we're eating, not necessarily the exercise. So how long does it take? If I cut down carbs and some of the other things that you all have suggested, how long will it take before I see those results?
Depends on what you're measuring.
This is go ahead, Dr. Jones. You can take it first.
It depends on what you're measuring, right? If it's your glucose and you got a continuous monitor on, you can see that days, right? A change in what your intake is will result in lower blood sugar readings immediately. Especially if you're taking medicine for your diabetes. So you change your diet, you're taking your medicine. Some people will say, by the end of the week, I was seeing low blood sugar readings. Increasing your exercise paired with a good diet, actually performance is, and this is Sora Fishray's, hen house, right? So I'm in her backyard. So I'm not going to stay in here long because this is not my expertise, but I can tell you that performance is actually the first thing that changes with any lifestyle. Before you shed a single pound, before you do anything, your body's ability to become more efficient is the earliest change you see in a change in lifestyle, if it involves exercise. So people will say, man, that first week I walked for 5 minutes and I thought I was going to die every time I did it. But I noticed by next Wednesday, I actually could walk for 10 minutes. It happens really quickly. Weight loss is different. So generally, I tell people on average, you can expect a 1 to 2 pound weight loss with a change in lifestyle, depending on what that change is and depending on how far away you are from your goal, right? So let's say someone has a BMI of 65. Well, if they started making some changes, they may overshoot the 1 to 2 pounds a week. They may see, 3 pounds that week, okay, a pound that week. But overall, when they get to the end of the month, maybe instead of 4 to 8 pounds, they saw 8 to 10. Well, somebody that's just trying to lose 15 pounds may only see a half a pound every week. And so they may undershoot the pound. So it really depends on what you're using to measure it. It's hard to know.
I was just going to say, because when it comes to I'm sorry, did I?
Oh, no. I was just going to say, yeah. So kind of echoing off that point. So with people that have like a higher, BMI, we still typically use just like as a gauge of where you're at. But, like you said, you can definitely see a quicker weight loss in people who are more morbidly obese, just because that they don't have that endurance that a person that, maybe a little bit overweight, has, already. So typically you can, with morbidly obese people or obese folks, you can actually see a large amount of weight. Like you can see like 20, 30 pounds within a couple of weeks or months versus like a person who's like maybe averagely overweight. They've been working out for the same amount of time, doing the same amount of exercise, and they may not see that amount of weight loss. And that's just an issue of endurance and also kind of like the type of exercise that you're doing at the time. So, you really shouldn't compare, the two. If you have a different starting point and you're, trying to lose that weight, I wouldn't. It's kind of tricky when you're trying to compare two people who have different weights that they're starting out with to begin with, because you're gonna get discouraged if you see, this person lost like 30 pounds in a couple of months, but here I am, struggling with like 10. That's not the way to look at it. And I kind of have to remind people of that you don't have that far to go, but this other person has a lot further to go, so you're going to see a bigger difference.
I'm gonna be honest. I think that this gets into really murky waters because I'm not sure what the particular question was about. I don't know if the question was, when will I see results, like physically see like weight loss, or when will my body present results? I think it depends on what the viewer is asking. But when I'm talking to my patients, I try my best not to focus primarily on weight loss. But this is just my approach. This is me, Dr. Thurston, Dr. Sunshine. This is just how I approach it. Because because I feel like sometimes patients like to associate weight loss with being healthier. And sometimes it doesn't work that way. Sometimes you are a healthier patient by changing your lifestyles, and you may not see that resulted on the scale. And like Dr. Jones was saying, you know, sometimes people get discouraged, things like that. So I try my best to discuss them with patients, sometimes in tandem and sometimes separately. But I agree with what Dr. Jones, to answer the question, I agree with what Dr. Jones was saying. So changes in like your glucose, like your sugar levels, days. Changes in your blood pressure, days. Changes in your cholesterol, a little longer. We usually don't check your cholesterol often, maybe every 3 to 6 months or so. So we don't check cholesterol often, and those are kind of things you'll see later. But if you're asking like, when can I see the changes on like a blood pressure cuff or something that's monitoring, days for most things, a little longer for cholesterol, depending.
Yeah, Dr. Tracie.
I also like to say, I definitely counsel a lot of patients because they get very frustrated. They're like, I'm doing all of this, don't see the weight loss, I'm discouraged. And sometimes I have to tell them, a lot of times you see that you lose inches first before you actually lose the weight, right? Mm-hmm. And it kind of also depends on what you eat as well. Sometimes you retain a little more water. Your weight can fluctuate a little bit depending on when you weigh. So like I try to tell them to stay encouraged and keep doing it, because it's not all about what you see on the scale per se. A lot of times you do have these small changes that you see your body every day, so you don't really notice it, right? Mm-hmm. But then you start realizing when you put your clothes on, oh, it fits a little better. Oh, I can wear these. So clearly what you're doing is working, right? But you might get frustrated because you don't see that the scale is really moving according to where you think it should be. So a lot of it is just managing your expectations.
Absolutely. I do have a couple questions that have come up in the chat or in the Q&A. One is about, is there some mantra or some mindset thing that we can do, we can say to ourselves to help? Because earlier in this conversation, Dr. Tracie talked about that sometimes people will, when you start making these changes, that they feel a little hungry because they're not eating as much as they would have in the past, right? Or they're eating vegetables and that's not as dense as some other type of food. So is there something or some mindset that we could adopt that kind of helps your mind with your stomach say, all right, stomach, you're fine. You can hang in there. Is there something that you all suggest for that?
Ooh, Dr. Jones should know this one.
I say drink water.
You know, I actually give people a lot of grace when it comes to that. So, you know, first, if the question you got to ask yourself is, are you hungry? Right? Let's start with that. Mm-hmm. Are you hungry? If the answer to that is yes, then go get something to eat, period. Like, because if the foods you're reaching for are just a better quality, then they're not going to burn you so much, right? The problem becomes that people have a good meal and then they're like, oh, I'm still hungry. They haven't really figured it out in themselves. Like, is this a craving? Is this true hunger? Is it thirst? Like, what is this? And then they're like, fine, you know, must not have worked. Let me go order Chinese food. If you're hungry, you know, is there more of the thing you cooked left? Like, do you want some more vegetables? Like, do you need a piece of fruit? Like, do you need to add a little fat to it? So I'm always like, I need, you know, for me, apples and peanut butter are a thing. Like, you feel me, okay? There are times at the end of the day where I'm not really sure that I'm hungry. And I'm not completely sure that I'm not, but I'm also probably eating for stress or boredom or something like that. And so my home is my safe zone. And so anything that I can reach for in here should not burn me so badly. And so there are nights where, yeah, I ate that apple peanut butter. I don't know if I was hungry or not, but I needed to eat it. But it was in the safe spaces that I've created in my home. I don't know, you know, Dr. Thurston says that I'm the mantra person. That's actually Dr. Sunshine, who is the mantra, you know. But, you know, I tell people to eat when they're hungry. So I'm going to let Dr. Thurston give you the mantra. I'm sure she's got something, but I don't have a specific mantra.
So I think that what's a little fun fact. So myself and Dr. Jones used to live together. So Dr. Jones, I've been with Dr. Jones through all of her healthy eating habits and healthy snacking and the whole shebang. But I will say this, I would much rather you eat more frequent, smaller, healthier meals than to eat unhealthy, big, heavy meals. So if you eat something healthy and then an hour or so goes by and you're like, I'm kind of munchy, same thing that Dr. Jones was saying, especially if your home is your safe place, safe as in anything that's in here should be healthy-esque for me, then it's fine to have a healthy snack. It really is. And if you need to add a little bit of fat to it, by a little bit of fat, you know, some people would say like, you know, if you want to have something with like cheese. So cheese is like a form of fat. If you wanted to, not fat like bacon fat, but fat like a cheese to add on to something. Either way, point is healthy snacking and eating more often. I would prefer that over unhealthy big meals. So I think that's fine.
Awesome. And then the last one kind of on this topic is about intermittent fasting. And does intermittent fasting maybe coupled with a veggie-based diet, does that help with these chronic diseases we've been talking about? You all are nodding.
It depends on.
It depends.
It depends, right? How you break your fast, and I like intermittent fasting. I have not done it in a little while, but that's just scheduling a couple other things. But people have found success from intermittent fasting. You know, I have probably unofficially steered patients toward intermittent fasting because they make bad decisions for breakfast. Like breakfast is not their thing. They're not good at planning it. And so they feel bad. By the time they feel bad, they're in the car on their way to work. And so they, turn into some driveway to get something really quickly. I'm like, fine, you know what? You're not good at breakfast. Let's intermittent fast feed, right? Let's just think about lunch as your first meal of the day so that you got time for your brain to turn on so that you can make a solid decision. I think that there are some benefits to intermittent fasting, but when you break your fast, it counts. Some people are declaring intermittent fasting, but what they mean is that they are intermittently binge eating, right? And so they're saying, oh, I have not had anything all day today. I am about to get this burger, extra large fried, Diet Coke, and then I'll have an apple. No, ma'am. You may meet the calorie count, right? Because they'll say, well, I only had 1,500 calories for the day. Now, why you have 1,500 calories a day in that one fast food is a whole other conversation, but it's going to meet a calorie requirement, right? So if you were tracking those meals through a online app, you're probably going to stay under your meals. You're probably going to stay under your, maybe you might stay under your fats. You're probably going to go over your sodium, but it's not going to get you the results. You're going to still have high cholesterol. Your blood pressure may not regulate, and you may not see sustained weight loss. So if you're going to do intermittent fasting, you need to stay hydrated. You need to have a plan on when you break your fast. And you need to give yourself some grace. So if intermittent fasting feels like a chore for you, then maybe you cannot do intermittent fasting 7 days a week. Maybe some days you get to say, well, on the weekends where I've got time to think about a healthy breakfast, on the weekends, I'm going to have a healthier breakfast because I've got time to process that. And then during the week, when I just don't do well at planning any particular meal, I'm going to structure my intermittent fast around that.
And Miney, I don't know if I guess the listener is probably talking about like the traditional 16-hour fast or the 8-hour fast and 16 fasting or something like that. But the point is that there's different levels of intermittent fasting. So there's like a warrior fast, which is, I would not recommend because you're essentially starving yourself for, I believe, 48 hours straight, which is not good. A lot of people typically opt for like the 12-hour fast. So you start, like what Dr. Jones said, you can start your first meal at lunch and then you go until, typically until like the end of the day, like when you're ready to go to bed, and then you can have water or some type of tea before you go to bed and then, start all over the next day. Some people may also do the 8-hour fast. So that typically lasts during like office hours. So you start at 9, you're done at 5. Your last meal is at 5, and then for the rest of the night, you only do like coffee, tea, or whatever, liquid stuff before you go to bed. So those types of fasts are fine if your lifestyle fits with that. Since I work nights, my day starts at 5, so it's a little bit different for me. I've learned that I'm not an intermittent fasting person, so I just opted to do the vegetarian part of it. But also the thing is that Dr. Jones had mentioned is that when people use calorie counters, that's fine and good, but you got to remember like the additives that you're adding to your meals and to your drinks and to your coffees, those all definitely add up throughout the day. So if you're adding like a crap ton of cream to your coffee or to your tea, you're adding like multiple spoonfuls of sugar, like, and syrup and all the other stuff, those really do add up throughout the day, and people do not track that. So if you're not seeing any results, I would kind of like circle back to that to see what you're adding to your meal and to see if maybe you can make some healthy substitutions or just opt to go without that altogether.
Okay, thank you. That's some good information. So trying to pivot just a little bit, because we had a ton of topics that we could talk about today, and that one was an important one. And you see all the questions that came in regarding that one. I would like to ask you, sorry, my dog is barking outside the door. I would like to ask about fibroids. Like, what kind of information would we need to know about it? How do fibroids turn to cancer? Like, will you talk to us about fibroids?
Well, I think that one of the first things we should talk about, or where it should start, I feel like whenever we talk about any condition, I think the first thing we should talk about is what are the symptoms that you might be experiencing to make you wonder if you have fibroids? Because a lot of times women may be surprised by their fibroids, but then when you ask them more details about their life, sometimes I'm like, you have all the symptoms, girl. Like, you have everything that was, the list is complete. You hit all the checks. So I feel like the most common symptom that most women have who do have fibroids is that you're going to have really, really heavy cycles. And I feel like sometimes especially when women are younger, when you talk to other people, especially other people in your family who have heavy cycles, sometimes people tend to normalize it. But as someone who personally has fibroids, I've had mine removed, which we can talk about that too. There was a long period of time, when you talk to your best friends and other stuff like, what? How many days, is your cycle? And how many this? And they're like, girl, that's a lot. And I'm like, is it? It's been like this for a really long time. And you just kind of fall into this trap of what is normal, right? And you're not really swapping. I mean, it doesn't come up too often, but anyway, long story short, heavy cycles is definitely one of the main things. Also, you're going to have really extreme cramping, menstrual cramping during your cycles too. That's like a major one. And then if your fibroids get really big, then you can also kind of feel like a pelvic pressure because basically you have like, this mass that's not really supposed to be there. And if you do have fibroids, especially if they're large, you'll start to feel like some pressure. And sometimes you'll feel the pressure even when you're not on your cycle, and you feel this pelvic pressure and you're kind of just like, I know I don't have to use the bathroom, or, what is this heavy feeling that I feel? So that's also something that women may encounter. I saw Noah put her hand up, so I didn't know.
No, I was just going to say, I just said fibroids are very common, like 2/4 out of people in this group have had them. And they're very common. They're extremely common among the Black women community. But yeah, the other thing is also like very bloating. That's very significant, can also be a side effect. And also, I would say urinary incontinence. If your fibroids get so big that they cause mass effect, which is essentially they're pressing on your bladder like 24/7, you can feel like that urge that you need to go pee, but nothing comes out. So that's another issue that can pop up with fibroids that can be really annoying. And that would be something I would definitely have you seek medical attention for.
Dr. Thurston, I just to make sure we answer Tracie's question, because it's important. I've had a lady come in panicked about what you asked, and it's important. What she said is, how do fibroids convert into cancer? And that's not a thing. Those are very different.
They do not.
So uterine cancers or cervical cancers, because your cervix is part of your uterus, are different from having fibroids. And I want women to know that, because people misunderstand it. So I've had people show up to say, Dr. Jones, why are you not terrified for me? You just got an ultrasound and you just told me I got fibroids. And she showed up with family in tow. And I was like, hey, everybody, I'm glad to see you, but we're talking fibroids, right? We're not talking cancer. Nobody's dying today. So they're not the same. So the fibroids are growths, so it's extra uterine tissue, right? Yeah. That tissue is very responsive because it behaves normally, right? Remember, cancers are tissues that do not behave normally. They do not follow any rules. They don't listen to things when they're supposed to. But fibroids are extra tissue that behaves normally. The reason why your periods are so heavy is because your fibroid, just like the rest of your uterus, responds to your hormone cycle. And so when it's time to have a period, they're like, me too, right? Like I'm now an extra part of your uterus. I'm going to go ahead and bleed. That's where Dr. Fisher and Dr. Thurston are talking about the heavy bleeding, the extra pressure and all the stuff, because it joins in with the rest of the group. It wants to be a member, right? Cancers are different. You can have a cancer of your uterus, you can have a cancer of your cervix, but it doesn't mean that because you have fibroids, you're going to have cancer.
Thank you
Awesome.
for the
Thank you.
clarification, Dr.
Yeah,
Jones. So I think the
absolutely.
way I said growth can mean, you know, when I say, I agree. Thank you.
Yeah, the medical language can be, you know, kind of scary for most people who are outside the community. So, you know, growth, mass, benign, neoplastic, metaplasia, those are all terms that doctors typically use to describe, you know, anything within your body. And we may reserve those terms for the fibroids. So if your doctor uses a word you're not familiar with, stop them and say, hey, I don't understand that. What does that mean? Because I'm guilty of that, and everyone in the group on our podcast, I frequently do that, and I do catch myself. I'm getting better, but it's still a problem. But essentially, you know, your fibroid is a benign, so that means not cancer growth on your uterus. So if we tell you have fibroids, you know, you can maybe breathe a sigh of relief, because we do have really good treatments to get rid of them. But you know, those terms can get thrown around, and I understand, you know, people do get scared, and we're sorry. We apologize.
And just to let people, and just to kind of like, to make sure everyone's familiar with the process, even though you have the symptoms and you bring it to your doctor's attention, your doctor's probably going to do an ultrasound, because there are some things that you can appreciate on the exam, like when you see your doctor, but your doctor is likely going to order an ultrasound. They should go over the ultrasound results with you. Again, this is when I draw pictures of the uterus and I say, this is where they are, this is how big they are. And then based on what they see on the ultrasound, by they, I mean the radiologist who's reading this ultrasound, they'll say, more than likely fibroids look like fibroids. If something looks a little on the fence, then there's certain ways that we can go in and get a sample and make sure that it is a fibroid. But 9 times out of 10 on the ultrasound, they can tell whether it looks cancerous or like a fibroid, because like Dr. Jones said, the tissues are drastically different.
So a lot of times with fibroids, it tends to a lot of times run in families. So sometimes you can talk to your mom or grandma and be like, oh yeah, I had that too. And so a lot of the fibroids tend to respond a lot to estrogen. So a lot of times the first line treatment that we do is put you on birth control to kind of regulate your periods, right? To kind of help with the growth, help to maybe stop the growth as much, right? And then what tends to happen is if you get off birth control, right, then they start growing again. So it really kind of all depends on how big it is, how much is it's impacting your life on some of the different treatments that we would do for it. Typically, when you hit menopause, fibroids don't really become an issue anymore, just because you had that loss of the estrogen hormones. So they kind of just shrink and just not be a problem anymore.
And then also, so yeah, that birth control is usually the first line of defense. But if your fibroids are so big, like they're causing pretty much like really bad symptoms that you just cannot live with day to day, then your OB-GYN or your family med doc will definitely recommend, you know, eval for potential surgery. Not every fibroid needs a hysterectomy. So you can still retain your uterus if you want to still continue to have children, you're at that age. And if you make those wishes known to your doctor, you know, hysterectomy is not the first thing that your doctor should be jumping to. There are other different types of procedures to remove the fibroids, some non-invasive. So your surgeon may opt to actually go in and remove the fibroids, you know, one by one. We typically call that a myomectomy. So you go in and remove the different fibroids that are scattered throughout the uterus, and that can help relieve a lot of those symptoms. The other procedure that is actually more along the lines that's non-invasive is actually a procedure called accessa. And that's where they actually go in via a laparoscopic procedure. So they make little incisions in your belly, and your surgeon will actually go in and they'll melt the fibroid on your uterus, and that can actually decrease, and it'll cause the fibroid to also decrease in size over time. So now there are different methods that your OB-GYN will definitely talk to you about more, but off the top of my head, those are definitely the ones that I just wanted to mention. So.
I was just going to say, to simplify a little bit what Dr. Fishray is saying, I think that once you have the conversation with your doctor is either going to have the conversation in more depth with you or refer you to your OB-GYN, and they should give you, in theory, they should give you a lot of different options for you to choose from regarding, like, again, the journey, regarding like, how do we manage this going forward? What are your plans for family planning? They're going to ask you a lot of questions because your doctor or your OB-GYN, they should be on the same team with you so that you can succeed at whatever your goal is. Some women don't want to have children. Some women want to have multiple children. Some women don't know. They're in the middle. So they should work with you to figure out the best way to manage it. And some women don't like being on birth control, and they have really bad aversions to hormones. Like, women, every woman is different and they have different priorities. So it's good to be in tune with your doctor.
I have a couple questions from the chat. Again, the first one is, how is ovarian cyst different than fibroids? Can you talk to us about that a little bit?
So ovarian cysts, they're, so if you think of the uterus, I always think of it looks like the head of a cow, kind of. And kind of at the arms, sorry, excuse my little thing. So at the arms, so the hands, you have your fallopian tubes, and those kind of go on, they rest along your ovaries. So ovarian cysts, they can be like little pockets of fluid that are on your ovaries. The fibroids can actually be in multiple places on your uterus. So if I'm like the body of the uterus and these are my tubes, the fibroids can be anywhere on the top of your uterus. They can actually be in the inside. They can be under the what we call the mucosa layer of your uterus, or they can actually be embedded deep into the tissue of your uterus. So those are all things that you would see on a regular ultrasound, and they have typically different treatments. If your cysts can be ovarian cysts, sometimes you don't need to do anything about, and they'll just progress. But with fibroids, if they continue to get larger, and they're not responding to your hormonal therapy that your doc has put you on, then they may require some additional intervention for it.
And then the second question was, does removing the uterus with the fibroids reduce the possibility of uterine cancer?
Removing the uterus.
Well, yeah.
Well, yeah. But almost, to be honest, I don't know the age of the person who's asking this question, but if you're having fibroids, it takes the very, very, very last resort is to remove the entire uterus. Almost every surgeon that you talk to is going to try their best to make sure that you can keep your uterus if you want to. Rarely are people like, let's just take the whole thing out. Like, that's usually very extreme. And if you hear that, that's a red flag. All the emojis, all the red flag emojis. So the answer to the question is yes. If you remove the whole uterus, then your risk of uterine cancer is gone. That is true. But rarely when you have fibroids is your surgeon going to jump to that. They're usually going to talk to you about how many you have, how big they are, the options that there are, and then how to maintain going forward. Now, there are a lot of women who are like, hey, I have a lot of fibroids. My bleeding is crazy. I've had all my kids. I'm good. And there's an elective hysterectomy that they can talk to. Usually you talk to your gynae about that later. And then that's something that the two of you can agree on if that's your desire. But usually no one's taking out your whole uterus just on a whim. No one's doing that.
My question, are you asking in the sense that you're thinking that because you have fibroids, your risk of uterine cancer is higher because of that? Is that what you meant by the question? Because I'm not
get back to us. Get back to us, viewer.
Yeah, yeah. If that's the case, we talked about, again, uterine cancers and fibroids are not the same, right? They don't convert one to the other. It isn't like, oh, I got this fibroid and bam, now it's uterine cancer. That's not how they work. They're very different. Can you have uterine cancer? You can get uterine cancer.
Mhm.
Can you have fibroids? You can get fibroids. Can you have both? Technically, yes. Does that mean that they were related? No.
That's what I was trying to figure out, if that's what they thought. I wasn't quite sure.
You know, one of the reasons why they do not like to take your whole uterus out. So some women say, well, what's the big deal? Well, your ovaries are your primary hormone producer, but there have been some studies. I think there was a study at Duke. They had a write-up on it that said that when you do a hysterectomy, when they kind of did like a survey of women were on average going through menopause about 2 years earlier. Now, 2 years in the grand scheme of things does not seem like a long time, but we earlier talked about the difference between men and women and healthcare. Well, women get a leg up on men as it relates to heart disease, because while we are fertile, we have better chances at not having heart disease, right? Our estrogen protects us. That thing that makes us nice and fluffy and warm and fuzzy on the inside and out protects our hearts. Then we go through menopause, which is cruel and unusual. But the estrogen changes. And when the estrogen changes over, that is when you start to see that women die at the same rate as men from heart disease. So they are thinking about, well, we want you to go through, going through menopause is going to happen to us as women, but we want to prolong it as long as we can, unless there's a really good reason to take your uterus. Now, some women say, listen, my grandmother had uterine cancer, or my grandmother had cervical cancer, and now I got these big gigantic fibroids. I've got 4 kids. I wish I would have another kid. You and this uterus can go on somewhere. And gynecology may say, okay, that's fair. You've got a family history here where the cervix may, you know, give you some problems. You're bleeding heavily. You're always anemic. You just, you know, you're on birth control. You like to get off of it. It's just not worth it anymore. You're done having your children. Maybe you are a candidate to have an elective hysterectomy. Yes, we're going to slightly increase your risk that you go through menopause early, but this may be just a better decision than all of the stress, right? Because being anemic comes with its own share of issues. So when you're trying to balance anemia or earlier menopausal symptoms, you know, the anemia is not, you know, we talk about it so easily because so many fertile women are anemic, but it's actually very serious. And so there are reasons to take the uterus. But it just kind of depends on what's going on.
And a lot of times when they take the uterus, they keep your ovaries for that particular reason. So they just take the uterus, but they keep your ovaries so that you don't necessarily go to like straight menopause.
Yes.
You have that hormone's still there.
This is not y'all's fault. Let me just say that. Let me just put this disclaimer out here, but I want to do this because I have this conversation with just about every woman in my office. A hysterectomy, by definition, is the removal of your uterus. Your uterus includes your cervix, okay? Your ovaries are not a part of your uterus. So when you are going to have a conversation, or if you have had a hysterectomy, your question to your surgeon is, did you take my whole uterus? A complete hysterectomy has nothing to do with your ovaries. Because women come in and say, well, I had a partial because I got to keep my ovaries. No, if you had a partial hysterectomy, there's some part of your uterus that you still got to keep. And it's important for us to know, because if that part was your cervix, which it often is, it's called a supracervical hysterectomy, then your cervix is still intact, and we need to do pap smears on you for routine health screenings. So the question that you have for your doctor is, can I have a hysterectomy? Yes or no? Does that make sense? If that is a good decision, are you taking my complete uterus, which includes my cervix? Am I having a total hysterectomy? Or am I having a partial hysterectomy, which has nothing to do with your ovaries, but instead is whether or not you kept your cervix? If they took your ovaries, they would call it a hysterectomy with oophorectomy. If you did not hear those words, even if you don't understand it, tell the nurse, tell somebody, write this down for me so I can put it in my purse so I can remember, because I'm not going to remember these terminologies another 5 years. So you can stick it somewhere important. So when you are at your new primary care doctor's office and you're trying to tell him or her, I ain't got nothing down there. I got nothing. And we're thinking, well, that's interesting. You haven't gone through menopause or anything. You got something down there. We want you to keep your ovaries. If we do not have to take your ovaries, we would absolutely not recommend you take your ovaries, because they're going to keep you out of menopause for sure, right? But if for something happened, you had an ovarian cancer, or you had endometriosis, and endometriosis is different. That's when that tissue of the inside of your uterus grows everywhere. What if it covered up one of your ovaries and they had no choice to take it? Then you may have had more than just a hysterectomy.
Just a little cherry on top here. For screenings, just so everyone is clear, we do pap smears on women until they're 65. That's why this is a problem. We're going to keep doing pap smear screenings on you until 65. And then women tend to go through menopause before that, of course. So then in between these times, some women get a hysterectomy, some don't. So then when it's time for me to be like, hey girl, hey, it's time for your pap smear, then that's when we enter these conversations of, oh, nothing's down there. And I'm like, are you sure nothing's down there? Because if there's something, we need to screen it for cancer. And they're like, no, they took everything. I'm like, did they though? And then we have to go on an exploration to see. And some women are surprised. And I'm like, you have a cervix here. We should be screening this. And they're like, that's not the surgery I thought I had. So that's why we're here. So yeah.
I wanted to mention, it also depends on what the indication, why you had the hysterectomy for the screening as well. If you had a hysterectomy for fibroids, then you don't need to get the screening, especially if they took your cervix. But if you had a hysterectomy because you had some type of cancer, cervical cancer, they still recommend you do some screening, just because sometimes they think they got everything, but they might not have gotten everything. So you still have to do those screenings. So that's why we ask you all these questions, because it's important for us to know, because so many times that they don't know and we don't have the records, and then something gets missed, right? So that's why it's really important to know what surgery you had.
For you to know. I get lots of people come to my office going, well, I don't know what's in your records. Do not trust the records. And don't trust me, right? I am not to be trusted when it comes to your history, right? If it is not in this medical record, I do not know. So any one of us in the outpatient setting, I currently take care of about 1,300 people, okay? That is about 20 people a day, 5 days a week. You see me once every 3 to 6 months. If you're very healthy, you see me once a year. There is no way that when you walk in there, and I know I'm saying hi and I remember your kids' names, I wrote it down, y'all, because it's important for me to keep up with that stuff, but I wouldn't remember it in my head. And so, we get new record systems and stuff like that. Our company just went through a new EMR. Some of that stuff then transfer over. And so I want you to keep this knowledge of the stuff that has happened to you someplace, because it doesn't always stay in our memory bank. So I'm asking about, well, when was your last colonoscopy? When was your last pap smear? And some patients are like, I don't know, look in your chart. And I'm like, there's nothing in here. We going ground zero.
Mammograms too.
Mammograms. When was your last mammogram? So keep up when your last mammogram was, keep up when your last pap smear was. Have you had a colonoscopy for colon cancer screenings? It may or may not be in our records. We will sometimes try to go and find it. But if I can't find it, then we're like, okay, well, do we do it again now to make sure we had it done? And people move, all kind of stuff. So keep up with your medical records.
That's such a good thing, because I remember one of my favorite doctors, he would always, ask me some question. And I'm like, wow, how did he remember that from 6 months ago? Well, he wrote it down. That's how he remembered that from 6 months ago.
I do.
But it made me feel like he was paying attention. So it was all good. So there was.
I'm sorry, reading the comment. That's fine. Listen, I don't.
It's okay.
I can't keep up with your pap smear. I won't know. I really won't. That's it. Write it down, right? I trust you. Exactly. Here's what's most important. When you all tell me something, I default to you have given me the right information. If we find out that we need to correct it, that's fine. But when you tell me like, no, this doctor, she checked my A1C, do not repeat it. I don't repeat it. I believe you. And so that's fine. Now, if you give me some bad information, then we're both stuck. So I just want you to know, like, we're here. I'm going to trust you, and your word is your bond, and I'm going to roll with it. So, but yes, please remember your stuff. Help me.
Absolutely.
Help me too, please.
There was one last quick question, and the question was, have you come across women, encountered women who have sought out hysterectomies but were refused by a previous doctor or had issues obtaining any kind of approval for a hysterectomy?
Yes.
Yes.
For lots of reasons.
Yeah.
Go ahead, go ahead, Christine.
A lot of it could be just your insurance company is just not going to cover it. That's kind of the main reason. And they want to see, especially with insurance companies, see that you have tried everything. You have tried the birth control, you have tried other procedures, right? Before they actually go to that. And do understand, a hysterectomy, that's a major surgery. This is not like a little minor surgery, right? So we try to do everything we can before we get to that point, right? So insurance companies not going to just be like, okay, yeah, they requesting the hysterectomy because the patient wants it, so let's do it. No, they want to see that you have tried this didn't work, this has been tried. Like, so yeah, that happens a lot of times.
And this comes from a process of not wanting to this is from do no harm, right? And so they are trying to prevent unnecessary procedures. And so anything you can fix with the lowest amount of effort is what you're trying to do. And you work your way up and you escalate it. Now, there's some reasons why women really do want to be escalated to something higher and not start there. That's a conversation. What you have to know is that you've got to understand your reasons why, and you've got to understand what the surgeon is saying. And it really does become a conversation between you and your surgeon on, okay, what is the ultimate plan going to be? And let me understand it. And you can express your concerns. I really don't want a myomectomy. I'm just, at this point, I'm just terrified because I've got 2 people in my family that have already died from cervical cancer. And, if this is going to be, if a hysterectomy may be down the line anyway, then I just rather you take it. Your surgeon needs to know that. But they do have to push it through insurance. They got to, document it in a way that says, here are all the conversations we had, and this is why we're deciding to or not to do it at this time.
All right, awesome. We've had some amazing information today. I took notes. I was doing them on the slide, so I didn't look like I was taking notes, but I was. And I hope that people have been able to walk away with something. I think one of my biggest takeaways is that word journey. And it's so funny because I use that word with my patients when I work with them, that, improving depression, improving anxiety, improving some of those mental health pieces. It's a journey and it doesn't get fixed overnight. It takes time. And I don't think I ever conceptualized my physical health in the same way using that word. And so that's one of my biggest ones that I'm going to walk away with. So let me say thank you very much to our Chocolate MDs, our doctors that have imparted so much to us today. So thank you so much for your time and energy and effort today. And then with that said, I'm going to give it back to our committee co-chair, Jen Fishray, and I hope this was a great day for everybody.
All right, well, that's a wrap, everyone. Thank you so much for your attendance this afternoon. I do hope that you took away from this a lot of valuable information that you can discuss with your own primary care physicians. I'd also like to give a huge thank you to the Chocolate MDs for taking the time to share their knowledge with us this afternoon. If you would like additional information or and to check out additional topics that the Chocolate MDs discuss, you can check them out on their IG website at the Chocolate MDs, their website, thechocolatemds.com, or email them any follow-up questions at or thechocolatemds@gmail.com. And I'd also like to give a big thank you to the Healthy Lifestyle Committee for coming together to help plan this panel discussion. I hope that we are able to host them again next year, that the Chocolate MDs will come back and share their wisdom some more, because y'all are great y'all are awesome. So
We can do
was,
this all day. We can do this all day.
You really can.
Thank you.
It's great.
And I would just want to say thank you guys for your attention and giving us the opportunity to do this, because we are very passionate about chronic care. This is our bread and butter. This is what we do all the time. And, you know, to get the opportunity to talk to more folks and try to make more people healthy, I mean, that's great.
Agreed.
Thanks for having us.